Hello, my name is Kunal Jajoo from Brigham and Women's, and I'll be speaking today about endoscopy in the anticoagulated patient. Thank you to the course directors for having me back. I have no disclosures relevant to this lecture. I would like to acknowledge the assistance of Dr. John Salzman with this topic. So today, our objectives include accurately assessing the risk of endoscopic procedures and antithrombotic therapies, to know how to manage these agents in patients undergoing elective endoscopies, to know how to stop, know how to reverse, and know when to restart these medications before and after the procedure, and also to understand how to manage antithrombotic medications in patients who are coming in with active GI bleeding, as opposed to the elective procedures that we'll be discussing. Of course, anytime we think about the risks of stopping or continuing antithrombotics for endoscopy, we have to weigh the risks of procedure-related bleeding versus the risk of a thromboembolic event. In general, the procedure-related bleeding is treatable, whereas a thromboembolic event can be devastating. When we're risk stratifying, we have multiple major considerations for endoscopy and the medications. Those include the procedural risk factors, which we will review in detail, as well as patient risk factors, including their underlying disease, the indication for the antithrombotic therapy, and the difference amongst the medications that they might be on, including aspirin, the P2Y12 inhibitors, warfarin, and the direct oral anticoagulants. When we think about procedural bleeding risk, we can categorize our procedures into high-risk bleeding, those in which a 30-day risk of a major bleed is greater than 2%, versus low-risk bleeding, low or moderate-risk bleeding, those less than 2%. And many of these are quite obvious, the high-risk bleeding including PEG or PEG placement, ERCP with sphincterotomy, endoscopic mucosal resection or endoscopic submucosal dissection, all in the high-risk category and not very controversial there. When we think about the low to moderate bleeding risk, there are a few here that in the literature are considered low to moderate risk, but many people may not consider as a low to moderate risk. So just to keep in mind that biopsying during endoscopy, colonoscopy, or flexible sigmoid endoscopy is considered low risk. Argon plasma coagulation is considered low risk, and even balloon dilation of luminal stenosis is considered low risk, whereas Buji dilation would be considered higher risk. Also, polypectomy of less than 1 centimeter would be considered low to moderate risk. Now that we've discussed how the procedures may be different in their risk stratification, we have to also think about how the patients may be different in their risk stratification. And when we look at the clinical indication for warfarin therapy, those patients who have a mechanical heart valve in the mitral position or a recent stroke or TIA, those would be considered a high annual risk for stopping warfarin therapy, a high risk of a recurrent event. Whereas those with a bileaflet aortic valve without any other risk factors would be considered low risk. In the category of patients in the column on the right with venous thromboembolic disease, those who've had a recent venous thromboembolism within the last 3 months, those with a severe thrombophilic state would be considered high risk. And then those who have a distant greater than 12 months ago VTE and no other risk factors would be considered low risk. And of course, we're still left with a relatively significant category of the medium risk that would probably require further conversations with their other physicians. So which medications are we thinking about here? We have the antiplatelet agents, including aspirin and thienopyridines, and then the anticoagulant medications, warfarin, and the direct oral anticoagulants. As we well know, aspirin results in irreversible acetylation and inactivation of platelet cyclooxygenase. The effect is for the life of the platelet, estimated to be 7 to 10 days. And this can lead to a prolonged bleeding time for 48 hours and rarely even up to 8 days. Aspirin's effect on endoscopy has been extensively studied in many of these old papers that I reference here. And in standard doses, aspirin does not increase the risk of significant bleeding when doing endoscopy with biopsy, colonoscopy with biopsy, even colonoscopy with polypectomy. Conversely, the risk of stopping aspirin has been shown to increase the risk of acute vascular syndrome. And aspirin withdrawal precedes 10% of acute vascular syndrome events. The time between stopping aspirin and the acute event can range from about 8.5 days for an acute coronary syndrome to 14 days for a stroke and 25 days for peripheral ischemia. So holding aspirin unnecessarily is not without risk. So the American Society of Gastrointestinal Endoscopy has specifically stated that aspirin should be continued for all GI procedures. If there is great concern in the category of high GI bleeding risk and a low thromboembolic risk, then you can consider continuing aspirin, or if you really feel that the risk of bleeding is great for the procedure you're planning, you can discontinue for 5 to 7 days. But in general, the recommendation is to continue aspirin for all GI procedures. How about in those patients who have come to us with a peptic ulcer bleed, and there's a question regarding whether they should be back on their aspirin or not? In this randomized controlled trial by Joseph Sung and colleagues when he was in Hong Kong, they looked at 30-day bleeding and mortality in patients who were either resumed on aspirin after presenting for a peptic ulcer bleed or given placebo. And you can see here that there was a statistically not significant slight trend towards 30-day bleeding in the aspirin group. However, there was a statistically significant difference in mortality in those who were given placebo. So we should be resuming aspirin after peptic ulcer bleed to protect these patients against thromboembolic and cerebrovascular events. This was addressed directly in our most recent guidelines from the American College of Gastroenterology and the Canadian Association of Gastroenterology. They put out a combined recommendation about 2 years ago. And patients with GI bleeding on cardiac aspirin for secondary prevention, we suggest against holding the aspirin. And they thankfully even address the situation that we sometimes may be in where somebody else has held the aspirin and when do you restart it? And so for patients with GI bleeding on aspirin for secondary prevention, in whom their aspirin was held, aspirin should be resumed on the day hemostasis is achieved and endoscopically confirmed. Switching gears from aspirin to the thienopyridines or the P2Y12 inhibitors. These selectively inhibit ADP-induced platelet aggregation. They do so at the level of the P2Y12 receptor and inhibit activation of the GP2B3A receptor. This inhibition takes several days to develop, with about 40 to 60% inhibition of aggregation in 3 to 5 days of use of these medications. And the duration of antiplatelet activity varies by drug. And so we'll talk about that a little bit. Here we see that clopidogrel, the original and kind of most common one that we see, and prasugrel are both considered irreversible medications, and they both have platelet inhibition on the order of 7 to 10 days. Whereas ticagrelor is a reversible medication, a reversible effect, and has platelet inhibition lasting for about 1 to 2 days. When we think about how these work together, many of our patients are on dual antiplatelet therapy, where aspirin on the left is inhibiting the effect of COX-1 and inhibiting the upregulation of thromboxane A2, thereby inhibiting platelet aggregation. Whereas the thienopyridines, clopidogrel, prasugrel, ticagrelor, are inhibiting the binding of ADP to the P2Y12 receptor, thereby inhibiting the efficacy of the GP2B3A receptor and reducing platelet aggregation. So 2 separate effects. These medications actually have a differential risk for GI bleeding as well. In this review of 12 randomized controlled trials totaling 60,000 patients, they compared the risk of GI bleeding with the newer 3rd generation inhibitors, such as prasugrel and ticagrelor, compared to clopidogrel. These 3rd generation P2Y12 inhibitors were associated with a slightly higher risk for GI bleeding, with a relative risk of 1.3. This increased risk was primarily for upper GI bleeds and for unspecified GI bleeds, but not for lower GI bleeding. And prasugrel was associated with the highest GI bleeding risk amongst these 3 medications. So what should we do for our patients who come in, high-risk patients who come in on these medications? For those who have had an acute coronary syndrome with a bare metal stent within the past 30 days or a drug-eluting stent within the past 12 months, we should really be considering delaying the procedure if it's an elective procedure and not stopping these medications without discussion with their cardiologist. In those patients who are coming in already for an elective procedure and are not in this high-risk category, for patients who are on dual antiplatelet therapy for secondary prevention, who are undergoing an elective endoscopic procedure, the ACG and CAG recommend temporary interruption of the P2Y12 inhibitor while continuing aspirin. For the less common patient who is just on single antiplatelet therapy with one of these P2Y12 inhibitors, they were not able to reach a recommendation in this consensus group for or against temporary interruption of these medications. So to give you my approach for these higher risk procedures in a lower risk patient, we do hold the P2Y12 receptor inhibitors for 5 to 7 days prior to the procedure and can most generally start the next day if there's good hemostasis at the time of procedure. There can be a conversation with the cardiologist if you're holding these and they're on a single agent, if they can be put on aspirin. But generally, those who are on single agent were not on aspirin for a specific reason. How about when we're talking about not the elective situation, but the patients come in with GI bleeding and are on these medications? Ideally, discontinue the P2Y12 inhibitors if possible, but we should be avoiding platelet transfusions. There has been no demonstrated benefit to provide platelet transfusions for these patients. If the bleeding occurred on one of the third generation newer agents, such as prasugrel or ticagrelor, could consider switching the patient to clopidogrel when you're ready to restart them. Of course, potentially with a conversation with their cardiologist. And of course, clinical judgment is key, and that communication with cardiology is key. Shifting from the antiplatelet agents to the anticoagulants, most commonly warfarin, which we know inhibits the production of vitamin K-dependent clotting factors such as 2, 7, 9, and 10, and also inhibits protein C and S. The onset of action is between 24 and 96 hours. There is transient reversal of its effect with fresh frozen plasma. The duration of that reversal is based on the half-life of factor 7, which is about 4 to 6 hours. And there is available 4-factor prothrombin complex concentrate, PCC, which is available as a reversal agent. The duration of action of warfarin is about 2 to 5 days. So for elective low-risk procedures, if the anticoagulation is temporary, the patient is on it only for a recent hip replacement or a recent venous thromboembolism, then ideally for an elective procedure, you would delay the procedure until they're no longer on the anticoagulation. If the procedure needs to happen with them on and it's a low-risk procedure, generally the recommendation is for no adjustment in anticoagulation, but keeping the INR well in the therapeutic range. We should also be avoiding the administration of vitamin K for elective procedures, as this has a prothrombotic effect and can make it very difficult for the patient to achieve therapeutic INR in the short days after the procedure. In those patients who have to undergo a higher risk endoscopic procedure, but have a low risk cardiac condition, we should be discontinuing their warfarin 3 to 5 days prior to the procedure and restarting the warfarin the evening of the procedure, given that it takes 2 to 3 days for it to have its effect. In those patients who have a high risk condition and require a high risk procedure, we should discontinue 3 to 5 days prior to the procedure, and to consider bridging. And we're going to talk a little bit about bridging with a low molecular weight heparin, or potentially a direct oral anticoagulant. Again, we should be resuming warfarin the evening of the procedure if hemostasis is achieved at the time of the procedure. The risks and benefits of bridging with low molecular weight heparin has been looked at in detail. And this was a retrospective study of 1,000 patients who had 3,000 polyps total. And they compared the outcomes with bridging heparin anticoagulation in 100 patients to the controls with no bridging, which constituted 900 of the patients in the group. The post-polypectomy bleeding rate was slightly higher in the heparin bridging group as opposed to the control group. Heparin bridging therapy increased post-polypectomy bleeding with an odds ratio of 8, and thromboembolism occurred in only one patient in the control group. What should we do when the patient has come in on anticoagulation and you find a small polyp, polyp less than a centimeter? We should be considering cold snare as opposed to conventional snare polypectomy. The immediate bleeding rate is actually lower with cold snare compared to conventional, and the delayed bleeding rate is significantly lower with cold snare compared to conventional. So for warfarin and elective endoscopy, for patients who are on warfarin undergoing an elective planned endoscopy, low risk, we suggest that warfarin can be continued. For patients who are on warfarin who hold warfarin in the peri-procedural period for an elective or planned endoscopic procedure, the ACG and CAG actually suggest against bridging anticoagulation. These are, of course, conditional recommendations, meaning that the patient's specific reason for being on warfarin have to be taken into account and may need to be discussed with their other medical providers. How about in the patients who come in on warfarin with GI bleeding? Do we need to wait until their INR has normalized before we can provide endoscopic therapy? In this study by our group, 233 patients were looked at after successful endoscopic therapy for bleeding, and about half of them had an INR of greater than 1.3, the vast majority of whom were lower than 2.7, so a typical kind of therapeutic range. And the rebleeding rate was not different in those who were anticoagulated versus those who were not anticoagulated. So INR is not a predictor of rebleeding, length of stay, transfusion, surgery, or mortality in this group. So endoscopic therapy is appropriate in mildly to moderately anticoagulated patients who come in with GI bleeding. Should we be reversing these patients when they come in with bleeding? The ACG suggests against the use of fresh plasma plasma. They also suggest against the use of vitamin K. They do suggest that if you choose to use a reversal agent, that 4-factor prothrombin complex concentrate, or PCC, which contains factors 2, 7, 9, and 10, should be chosen over FFP if you choose to use something to reverse the warfarin. And again, these are all conditional recommendations. Once we have stopped the GI bleeding, how soon can we resume the warfarin? And should we be considering resuming warfarin? This study, interestingly, looked at 90-day recurrent GI bleeding versus 90-day thrombotic event on patients who resumed warfarin versus those who were held from warfarin because of the concern of rebleeding. The rate of recurrent rebleeding was trending towards higher in the warfarin resumption group, but this was not a statistically significant difference. However, the rate of 90-day thrombosis was significantly higher in those who warfarin was held versus those who warfarin was resumed. So again, a non-statistical change in recurrent GI bleeding, which is almost always treatable, versus a statistically significant change in thromboembolic events, which is often devastating. So if you have stopped the bleeding, we should continue the warfarin if there were mild bleeding and maybe reduce the target INR to a tighter therapeutic range of 2 to 2.5 instead of 2 to 3. And of course, their INR levels should be monitored closely to avoid any unnecessary rises above the therapeutic range. If the patient is has an indication that would serve well with the direct oral anticoagulant, then you could consider switching from warfarin to a DOAC, especially if they've been having a history of difficult controlled INR levels. Again, we have to remember that not all indications are appropriate for these medications, and some patients just need to be on warfarin. If the bleeding occurred on dual therapy with warfarin and aspirin, then a discussion can be had with the cardiology team about whether one or the other is an option. Speaking about the direct oral anticoagulants, These can be factor 10A or 2A, also known as thrombin inhibitors. These are known to be at least as effective as warfarin in preventing strokes and atrial fibrillation. This is an oral fixed dose without coagulation management. So you don't have to have, these patients don't have to have frequent INRs, as you know, improving convenience and potentially improving compliance. Therapeutic anticoagulation occurs very quickly, and normal coagulation resumes within 24 to 48 hours after the dose is held. So currently on the market, we have 10A inhibitors, apixaban, rivaroxaban. We don't really see edoxaban much. And then the 2A or thrombin inhibitor, dabigatran. The pharmacodynamics show a very, very quick onset of action after starting these medications in blue here, as compared to warfarin, which, as we know, has a very slow onset of action. And then on stopping these medications, prompt resumption of normal coagulation parameters 24 to 48 hours later, whereas, as we know, warfarin is a much slower normalization. How do these medications look in terms of comparing bleeding risk for direct oral anticoagulants versus warfarin? When we look at the International Society for Thrombosis and Hemostasis major bleeding category, they actually favored the direct oral anticoagulants overall, especially when it comes to intracranial hemorrhage. However, when we look at major gastrointestinal bleeding, it actually favors warfarin. These medications also have a bit of a differential when it comes to major GI bleeding, whereby dabigatran and rivaroxaban are more likely to be associated with major GI bleeding compared to warfarin, whereas apixaban is not statistically different from warfarin in terms of the major GI bleeding risk. These can be a little bit difficult to think about how we have to stop them before endoscopy, because it's differential based on creatinine clearance. And so we often ask our triage nurses to keep this chart handy, and as well as the pre-anesthesia testing center to keep this chart handy, to think about when the patient should hold the medication prior to elective procedures. There are now reversal agents available for these medications. There is a monoclonal antibodies with specific affinity for dabigatran. It has been shown to eliminate the dabigatran effect within 5 minutes after 2 IV doses, but it is exceedingly expensive. This was approved in 2015. There is also a factor 10A inhibitor reversal agent, adnexit, a recombinant protein specifically designed to reverse the anticoagulant activity of both direct and indirect factor 10A inhibitors. It is administered as a bolus plus infusion, was approved in 2018. These do result in excellent hemostasis effect, but we will just note that there was no control group when comparing these. And so specifically for gastrointestinal bleeding, they were able to achieve excellent hemostasis of about 85%. That being said, the ideal way to manage patients coming in with GI bleeding on one of these direct oral anticoagulants, mostly we can manage them with holding the drug and providing IV hydration. The reversal agents, as I mentioned, are available. However, our American College of Gastroenterology recent guidelines from 2022 actually suggests against the use of these reversal agents, given their cost, lack of reproducible benefit, and lack of a control group for the adnexant study. If the patient is on one of the other direct oral anticoagulants, you can consider switching them to apixaban after an event of GI bleeding. As I showed you earlier, that has a lower overall risk, and it's more comparable to the Coumadin risk. There remain some disparities in care, unfortunately, when it comes to our patients on anticoagulation. Disparities in both the initiation of anticoagulation and the type of anticoagulation have been demonstrated, where we know that Black patients are less likely to be given one of the newer direct oral anticoagulant agents and may be on warfarin with frequent INR checks. And this can compound the known disparities in colorectal cancer screening rates, given the greater difficulty in managing bridging and in managing INR while on warfarin. So regarding our take-home points for today's discussion of endoscopy in the anticoagulated patient, endoscopic procedures may be performed on patients taking standard dose aspirin, and the aspirin should not be stopped. For high-risk procedures and patients on dual antiplatelet agents, hold the P2Y12 inhibitors, but continue the aspirin. For patients on warfarin, if they are undergoing a low-risk procedure and their INR is in range, you can continue the warfarin. For high-risk procedure, you want to hold the warfarin and avoid a low molecular weight heparin bridge unless they're at a very high risk for thrombosis. The direct oral anticoagulants have a rapid onset and offset, but an increased GI bleeding risk. Reversal drugs are available, but currently advised against unless there's life-threatening bleeding. And for high-risk patients, thromboembolism, we really should be restarting these medications immediately after bleeding is controlled and at the very most 7 days to reduce their risk of a thromboembolic event after their GI bleeding event or after their elective procedure. Thank you very much.